I'm going to move on to the next half-hour debate. Trust Special Administration of Mid-Staffordshire NHS Foundation Trust. Jeremy Lefroy.
Thank you. Thank you very much, Mr. Crosby. It's a pleasure to serve under your chairmanship. And given the interest of several colleagues from the area, with your permission, I'm going to take a number of interventions in the course of my remarks. On the 18th of December, the administrators of the Mid-Staffordshire NHS Foundation Trust published their final report. It recommended the dissolution of the trust as soon as possible and the absorption of Stafford and Cannock hospitals into the University Hospital of North Staffordshire and the Royal Wolverhampton Trust, respectively. It also set out proposals for the services which would continue to be offered at both Stafford and Cannock. The total cost over 3 years will be £220 million, of which 63 is revenue and 157 capital. Let me first address the proposal to dissolve the trust. This is, I believe, the right thing to do. It will enable both Stafford and Cannock hospitals to work much more closely with larger specialist teaching hospital trusts. They will then both be able more easily to recruit clinical staff who see greater opportunities for skills development within a larger organisation working across 2 or more sites, and it will also reduce overhead costs. But the administrators' proposals don't go far enough in ensuring that the interests of those who currently use MSFT are fully taken into account. So Monitor and the Secretary of State clearly need to state that the expanded trust should immediately recruit suitable non-executive directors from the areas served by mid-staff, such as Stafford, Cannock, Penkridge, Rugeley, Stone, Brood and so on, to ensure that these areas are properly represented. And they should also, of course,
under the proposals, the University Hospital of North Staffordshire is going to take over Stafford Hospital. North Staff's hospital has a deficit at the moment caused by reopening beds to cope with the blockages at A&E and in admissions. Would you agree that in taking over Stafford Hospital, it's very important and in everybody's interests, in Stoke-on-Trent, Newcastle-on-Lyme and Stafford, that the University Hospital of North Staffordshire has the prospect of financial stability?
I thank the Honourable Member for his intervention, and I entirely agree with him. I would see more of it as 2 hospitals coming together, but it's vital that the financial difficulties that UHNS are facing are sorted out, and I would particularly urge the government to look at the PFI cost, which is too great for that particular trust. Of course.
I'm most grateful. To congratulate the Honourable Member on securing this debate. Just further to that point, can I point out for the record, so that when the Minister comes to reply, hopefully he can give cast-iron assurances about the financial input that will be needed for this reconfiguration to take place, addressing the issue that the UHNS, University Hospital North Staffordshire, has identified that additional expenditure needed for service configuration is in the order of £29 million, whereas the TSA has said that only £13 million would be needed, and that the TSA has also proposed a cost improvement programme of 8.5%, whereas Monitor has said that anything over 4.5% is dangerous, and we need to have a very clear, detailed calculation and input from the government as to how these extra costs are going to be met, taking on board as well the issue about PFI.
I thank the Honourable Lady for her intervention, and I entirely agree with that. There's no point in Stafford merging with Stoke with the consequence that we have a trust which is financially failing in future. Now, the administrators rightly place emphasis on the need for swift action, and I believe that the dissolution of the trust in the autumn of this year should be possible, indeed even earlier than that. I would go further. The trust, the Mid-Staff's trust, has improved greatly in recent years following the huge failings brought to light through the vital work of Cure the NHS and documented in the Francis report. Its recently published HSMR figures were the best in the West Midlands, but it is fragile and it finds it difficult to recruit in some areas. So we need the overall arrangements to take immediate effect, even if in shadow form. In recent weeks, I've detected less engagement that is necessary because of the uncertainties of the administration process, and that needs to stop. This is all taxpayers' money. It's our National Health Service. It's time to work together, of course.
I thank the Honourable Gentleman for giving way and for not only securing this debate, but also for the work that he's done over recent years. He used 2 words in his recent comments: fragility and uncertainty. he will understand the fragility and the uncertainty of the healthcare economy in Staffordshire itself. My own hospital, Queen's Hospital, is a Keogh hospital. It itself has huge financial debts and is struggling to survive. Does he agree with me that it's absolutely essential that this reorganisation takes place and is properly funded? Because if not, the knock-on effect to other hospitals like Queen's and the wider healthcare economy could be incredibly damaging, and we could have a domino effect where other hospitals fall over.
I thank my honourable friend, and he is absolutely right. We must make sure that we do not, as it were, jump from the frying pan into the fire. We must get to a sustainable condition for the health economy. So these new overall arrangements must take immediate effect, and I would urge the Minister to make that clear today, to give confidence to the various managements to get on with their work. One final point about the future UHNS and indeed Royal Wolverhampton Hospital. The Secretary of State has rightly emphasised patient safety and care since the publication of the Francis Report. The new expanded trusts have the opportunity to become national leaders in zero-harm healthcare. So I urge Monitor and the Secretary of State to seize the opportunity to support them in doing this at this time. Let this administration not be a dry legal exercise, but let it be a chance for Stoke, Stafford, Cannock, Wolverhampton and Walsall to become even more shining examples of the best 21st century healthcare, of course.
I thank my friend for giving way and congratulating you on securing this debate. I don't think there's any other member of the House of Commons who's had to deal with a local hospital issue so all-consuming and difficult as Stafford. And I congratulate him on behalf of everyone on his tireless dedication for getting the best deal for his constituents. He mentions Cannock Chase Hospital, which of course is in my constituency and is also the other hospital run by Mid-Staff's Foundation Trust, and will be taken over by Wolverhampton as part of the administration process. I welcome that abolition of that trust, which left my hospital 50% empty, and even as we speak today has just closed Littleton Ward to decant nurses to Stafford to try and shore up Stafford. Would my honourable friend agree that we cannot wait until later, the back end sometime of this year, for Wolverhampton to take over running Cannock and UNHS to take over running Stafford, that we need to move to the new organisational structure as soon as possible, in weeks, not months, so that both of our hospitals can have a secure future and that the staff can know their jobs are safe?
I thank my honourable friend and entirely agree and welcome the huge support that he's given both to Stafford and Cannock throughout this process. I know that the honourable lady wants to intervene about Walsall, so I'm happy to do so, and then I will continue on services.
To my honourable friend for giving way and for securing this debate, and I know how hard he's working. Could I just echo my honourable friend from Cannock Chase's tribute to him? The impact on Manor, as he mentioned, the Manor Hospital in Walsall has been immense. We've already had to open 70 beds, as well as they are attempting to open 2 wards. The hospital desperately needs 40 million. It's a matter I've raised frequently with the Minister, and so I'd be grateful if the honourable member could take that on board in his speech and in his summing up, and if the Minister could possibly look at the Manor Hospital. I know he's visited, although I wasn't actually there when he visited the Manor Hospital, to ensure that the Manor gets the funds that they desperately need for having taken the impact of the closure of accident and emergency at Stafford Hospital.
I'm most grateful, and I would like to place on record my thanks to all the staff at all the hospitals, Stafford, Cannock, Wolverhampton, Walsall and Stoke, for all they've done through this very, very difficult time. I'm now going to move on to the details of the services, which are obviously the bulk of the TSA's report. We've come a long way from 11 months ago. Then the contingency planning team recommended removing A&E and all acute services from Stafford, as well as elective surgery from Stafford and Cannock. We now have proposals which retain elective surgery at Cannock and indeed foresee increased activity there. At Stafford, we retain 14/7 A&E together with acute medicine, elective surgery and some less serious non-elective surgery, day case surgery and a large outpatient department. As a result of the consultation, the administrators have proposed a midwife-led unit for maternity when their original proposals removed all childbirth from Stafford. And the estimate is that some 90 to 91% of all current patient attendances would remain at Stafford and Cannock. I give way to my honourable friend.
I thank my honourable friend for giving way. I think most of my constituents, and sure many of his, would find it absolutely deplorable, the idea that Stafford Hospital won't have a consultant-led maternity unit, and the pressure that this is going to place on so many hospitals, whether it's Walsall Manor, New Cross, Queen's, or the University Hospital North Staffordshire is going to be unsustainable, and urge ministers to look at this again.
I'm most grateful to my honourable friend, and I will come on to that. It's an extremely important point. And just at this moment, I want to pay tribute to, because of the impact of their campaign, to the work of Support Stafford Hospital. The campaign which they've run has shown just how much the community values the services at Stafford and Cannock. And I'd also like to pay tribute to the working group which I set up, and all those who worked with me on that to provide us with the detail and alternative proposals, some of which I shall outline today. There is no doubt that the administrators have listened carefully to what has been said in the consultation and made a number of changes in their final proposals. However, the proposals as they stand are insufficient. What I'm now setting out does not require a redoing of all the work of the Trust Special Administrator. Given what I've said about the urgency of the situation, that would not be sensible. But it's a modification of the detail. I do not even believe that it would necessarily require more money than is currently proposed, although that remains to be seen. But it would be of huge benefit to many thousands of my and other honourable friends and members' constituents. It will also ensure that both Monitor and the Secretary of State can fully comply with their legal obligations under the 2012 Health and Social Care Act in respect of health inequalities, as I will show later. My proposal is that in 3 areas where it's proposed that services will be cut at Stafford, they instead continue, but in a more cost-effective form, at least for 2 or 3 years. I and the clinicians at Mid-Staffs consider that this will be quite possible to show how these services can be run across 2 sites in Stoke and Stafford on a networked basis. The areas are paediatrics, obstetrics, maternity and critical care. Firstly, critical care. The report proposes a reduction of the critical care unit to 4 beds. It says that the possibility of the highest level of critical care, level 3, should be maintained, but it is not clear how this is going to be possible without a rota of specialists in critical care. The department in Stafford has made their own submission to the consultation, which suggested a reduction in beds and a networked specialist rota. That seemed to me to be eminently sensible. Given that the CCU at Stafford is a net contributor and supports several other activities, I'd urge Monitor and the Secretary of State to determine that this model is tried for a period and hopefully proven to operate well, clinically, operationally and financially. The TSA's final report also proposes, as my honourable friend for South Staffordshire has mentioned, removing the consultant-led obstetrics and maternity service and replacing it with a midwife-led unit dealing with approximately 350 to 400 births a year. This is a step forward from the draft report, which proposed no childbirth at all at Stafford. However, I and my constituents do not believe that this is sufficient. Currently, Stafford sees more than 2,000 births a year, and this is likely to rise with the extensive house building, the various new business parks being built and doubling in size of MOD Stafford, to mention but some developments. That means in coming years, even with an MLU, probably some 2,000 plus babies being born in other maternity units, mainly Stoke and Wolverhampton. UHNS in Stoke already sees around 6,000 a year, and their population is also growing. With at least 1,000, probably more from Stafford, they'll probably approach 8,000, which is the number currently born at the largest unit in the country, which is, I believe, in Liverpool. The NHS rightly promotes choice for women as to where to have their babies, and the Prime Minister himself has spoken with concern about the trend towards even larger units. Yet that's precisely what's being proposed here for women who are unable to use a midwife-led unit due to the possibility of complications in childbirth. There would also be an impact on those who currently use UHNS and the Royal Wolverhampton, as their local units would become even busier, and that would probably include Walsall as well, taking in women from a much wider area. My proposal, and that of the clinicians at Stafford, is to continue with the current service, fully networked with UHNS, while the impact of the current rise in both the population and birth rate is assessed. It would also enable the Special Care Baby Unit at Stafford to continue to support the regional intensive care network for babies as it currently does. An added benefit will be that women will continue to have an obstetric and gynecology service locally, which I'm sure the Minister would appreciate, being from that speciality himself, again relieving pressure on the larger University Hospital of North Staffordshire and Royal Wolverhampton Hospital. Thirdly, Mr. Crosby, paediatrics. The TSAs proposed reducing the paediatric assessment unit to 14 hours a day from 24 and doing away with inpatient paediatric beds. There would be no paediatric rota, although A&E doctors would receive extra paediatric training and paediatric outpatients would continue. The principal reason which the TSAs give is national standards of the Royal College of Physicians and Child Health, which state that such services should be provided by a full consultant rota, which is usually between 8 and 10 consultants, whereas at Stafford it's between 5 and 6. Let me be clear about the consequences of this. If this is allowed to happen, then the clear logic is that dozens of other paediatric units around the country, which have similar numbers of consultants, or indeed fewer, must be closed or drastically curtailed in their activities. Monitor cannot use the argument that this must happen at Stafford but not at other foundation trusts or indeed NHS trusts for which they or the Trust Development Authority are responsible, and nor can the government. The argument that all inpatient paediatric care should take place in the largest hospitals is not accepted by the general public. They fully understand why very sick children should go to specialist units. They do not understand why their local general hospital cannot receive sick children at night time or for short stays, and nor do I. However, if this is an argument which experts at the Royal College insist on making, let it be open, let it be consistent across the land, and let it be agreed by all political parties. It should not be implemented by stealth through a trust special administration, which in no way arose as a result of the performance of the paediatrics department at Stafford. One final point, Mr. Crosby, of course.
William Cash.
Friend, because I've been waiting until this moment as he was concluding his remarks to say how much I support my honourable friend in his endeavours on Stafford Hospital, which affects my Stone constituency, and in respect of which I had to fight so hard to get the public inquiry which has led to many of the changes. But having said that, I simply would like to say to my honourable friend, many congratulations on it. I support pretty much everything that he says, and I really believe that he's done an enormous service to his constituents in the work that he's achieved over the last few years.
Jeremy Miller-Fry.
Well, I'm most grateful, and I would repeat those comments in respect to my honourable friend from Stone, who has likewise supported the trust and supported the work that's been done tremendously. My final point, Mr. Crosby, is that the children and families who will be most affected by the proposal on paediatrics are those on the lowest incomes. They're the least likely to have access to private transport to take their children nearly 20 miles to the nearest hospital at night. For them, public transport in the daytime is often poor, and a taxi fare is beyond their means, certainly if it means visiting a sick child several times. I believe this is a matter of fair access to healthcare from those on low incomes, and that is a responsibility which both Monitor and the Secretary of State need to ensure. The Paediatrics Department at Stafford also put forward an alternative in their response to the consultation. It was measured, and it did indeed understand the need to cut costs. It proposed a reduction in the number of inpatient paediatric beds and consultants working in a network within the new trust across both sites. You'll see a pattern here, Mr. Crosby. Critical care, maternity and paediatrics. There are sensible alternative proposals which have been put forward, of course.
Hello.
I too echo both the sentiments of other honourable members around to the honourable gentleman for raising this debate, and also actually echo the sentiments of my honourable colleague and near neighbour in Stone constituency about the proposals. But just a point before the honourable gentleman concludes his remarks. 2 points really. One is absolutely right in terms of there are other really sound alternatives that need to be looked at very, very quickly and a proper process put in place. But also the impact across the whole of North Staffordshire, indeed across the whole of Staffordshire, of this situation cannot be underestimated. And I think it's really important, and hopefully the honourable gentleman will agree with me on this, that actually there is probably no right solution in this, but what we've got to do is get the nearest to right solution.
I entirely agree with the honourable gentleman, and again appreciate the support which he and colleagues from Stoke-on-Trent and Newcastle and across Staffordshire have given in this. We've worked together, which I think is a great achievement in what can be quite a political area. So, Mr. Crosby, just to conclude, surely it makes sense to work with these proposals of clinical networks while Stafford is joining the expanded UHNS, with things are roughly as they are at the moment for a period of 2 to 3 years, because I believe these network solutions can work. If they do prove as effective as the clinicians, and I think they can be, we will have achieved the objective of services which are financially, clinically and operationally sustainable in Stafford and indeed elsewhere under the expanded UHNS, which are welcomed by my constituents and which will reduce the potential pressure on the other hospitals such as UHNS, the Royal Wolverhampton and indeed Manor in Walsall and Burton.
Minister, Dr. Daniel Poulter.
Thank you, Mr. Crosbie, and it's a pleasure to serve under your chairmanship, and a great pleasure, as always, to respond to my honourable friend, the member for Stafford, and indeed to all honourable members and right honourable and honourable friends who have contributed and supported in this debate today in raising what is an important issue, not just for patients and constituents in my honourable friend's constituency in Stafford, but also across the wider areas of Staffordshire and the region. It's been an incredibly difficult time for local patients and for indeed local staff at the Mid Staffordshire Trust, and I agree entirely with what my honourable friend said in his remarks, that the Trust has come a very long way since the terrible events which were exposed in the inquiries and in the Francis report last year. It's been a journey which he has walked every step of the way with his constituents and with those patients, and my honourable friend should be congratulated and commended for his strong and superb advocacy of the needs of local patients and of the needs of all of his constituents, the families of those who were treated appallingly in the past at that trust, and also for his strong advocacy for the improvements and the high quality care that is now being delivered throughout parts of the trust at Mid Staffordshire today. And I'm sure we'd all like to put on record our congratulations to his advocacy and the work he's done, and indeed also that of the right honourable member, my right honourable friend, the member for Stone, who for many years has also been a strong champion for local patients in the area. But Mr. Crosbie, it's important, I think, in outlining and responding to some of the points that were raised in the debate today, to talk a little bit about the background position of the Trust, which is important in putting things into context. Now, the Mid Staffordshire Trust has been operating at a deficit for quite some time, and certainly since 2009. In April 2013, it reported a deficit of 14.7 million. This position is, as our friend alluded to, expected to get considerably worse. As a proportion of its turnover, the deficit forecast for 2014 is higher than that of almost any other trust in the country. For the past 2 financial years, the Trust received approximately £20 million a year in support from the Department of Health, and without this funding to supplement its income, Mid Staffs would have been unable to pay its staff. A contingency planning team sent into Mid Staffs in late 2012 concluded that the Trust was delivering services at a cost substantially higher than most other trusts in the country, and a key challenge faced by the Trust is the recruitment and retention of staff and the high cost of temporary staff. And it's no wonder that is a challenge, given what must have been a very demoralising demoralising time for those staff who are working at the Trust when there have been ongoing investigations to events that took place in the past. In addition, some of the Trust's services are operating with consultant numbers significantly below Royal College guidelines, and the team that was sent in 2012 report noted that despite improvements in clinical services, it was unlikely that the Trust would be able to achieve the cost savings required without adversely impacting on the quality of care provided to patients. On the issue of special administration, and then leading to why the special administration process has been set up, it's important to take that initial report into account and recognise it's from that report that we are where we are today. And it's crucial that in cases such as this, where a trust is facing substantial financial challenges, action can be taken quickly to secure services for patients and make sure that high quality patient care can still be delivered. The special administration process for foundation trusts offers a time-limited and transparent framework for resolving problems of the significantly challenged trust, and like the regime for NHS trusts, is intended to be used only in the most serious of circumstances. As my honourable friend is aware, Monitor made the decision to place Mid Staffs into special administration on the basis of the 2012 work, and the CPT's first report concluded that Mid-Staffs is not financially or clinically sustainable in its current form, and recommended the appointment of administrators as the best option for identifying the changes and that were required in the years going forward to continue to secure high-quality patient care. And acknowledging also the serious financial challenges faced by the Trust, Secretary of State for Health wrote to Monitor giving his support for the appointment of the TSA. So it's worth briefly touching on the work of the TSA at Mid-Staffs. The Trust Specialist Administrators have been in place at Mid-Staffs since April of last year, and they've had two tasks. First of all, they had to take over the day-to-day running of the Trust, and secondly, to work with the Trust staff, commissioners, providers, and other local stakeholders to develop a plan for services. The work undertaken by the TSA builds on the earlier conclusions of the CPT and only strengthens the case for urgent change. I will in just 1 second. And the TSA's estimate that if no action is taken in 4 years from now, Mid-Staff's annual deficit would exceed £40 million. And of course, I'll give way.
I'm very conscious about the amount of time that's left in this debate in order for there to be some very specific replies to the points that have been made both by the Honourable Member for Stafford and from the interventions. I just wonder if the Minister will be making sure that the issues that have been flagged up will actually be responded to in detail in this debate.
Well, I will, of course, respond to those that I can, but as the Honourable Lady be aware that, and as I will come to later on, the report from the TSA is currently with Monitor, and it would be due to be recommended to the Secretary of State, I would expect, by the end of this month. And whilst it would be inappropriate for me to comment on the report at this stage, so I hope you will understand that and understand that it will be wrong for me to make assumptions upon a report that's not yet been submitted to the Secretary of State. I will give way very quickly, but I'm conscious of time.
I've asked nearly 10 times for a report to be debated on the floor of the House in government time. It hasn't happened yet. Nobody can understand why it hasn't happened. Could we please have an assurance that it will take place and within a matter of weeks?
My right honourable friend makes a very important point, and my right honourable friend, the Secretary of State, has previously given that assurance, and I will give him that assurance again today. It's obviously a matter for the Leader of the House to organise government time, but I will have conversations with him and write to him following this debate to ask him to expedite the issue as my honourable friend requests. So just returning back to the TSA report, the TSAs have also highlighted the serious clinical implications of failing to act. They predict that services operating below the recommended consultant level, such as A&E, would need to be reduced, and low-volume services would risk being closed altogether, forcing patients to travel further for treatment. Throughout the process, the Trust Special Administrators have stressed the fragility of the Trust and emphasised the huge importance of agreeing and implementing the changes required as soon as possible. But on to the next steps, which is an issue that I believe all honourable members are concerned about. And I know it's frustrating today for honourable members who want answers that I can't give all those answers to the dispatch box today, because it's very clear that when the report is currently with Monitor, that it is a matter for Monitor to then make recommendations to the Secretary of State on the basis of that report, and that will be the appropriate time for the Secretary of State and Ministers to comment. And I know that may be frustrating to honourable members, but that is the way that things need to be, because we can't comment on the matter until Monitor have made those recommendations. And if Monitor is satisfied with the Trust Special Administrator's final proposals, the Secretary of State will, as honourable members will be aware, have maximum of 30 working days to consider them against a set of requirements which are defined in legislation. And these aim to secure services for patients which have sufficient safety and quality and offering good value for money. I know that the Secretary of State will be considering each of the requirements carefully before coming to his final decision. And as I've stated, the TSA's final report, because it has not yet been finally submitted, it would be inappropriate for me to pass any further comment today. But it's very clear from the debate we've had that there is widespread interest around the region from local members who are concerned about the wider impacts of the TSA's report on the health